transcatheter hybrid procedures, being presented by Dr. Luigi Pirelli.
Thank you very much. I have no disclosures. Direct aortic is an alternative approach for TAVR, and multimodality imaging, including CT, echo, and fluoroscopy, is essential for planning and conducting the procedure. Objective of this study is to evaluate the safety and efficacy of multimodality fusion imaging in the planning and guidance of a direct aortic approach in TAVR. Image fusion is referred as merging and visualization of image data from more than one source to present the same information in a more meaningful and synergistic manner. You can see here two examples of fusion. On the left panel, the fusion between CT and fluoro with a software named Heart Navigator, and on the right, the fusion between echo and fluoroscopy utilizing the Echo Navigator. And again here, you can see the screen that the operators will face, in which on the right bottom panel, there is a fusion of CT and fluoro, and on the upper right quadrant, you can see the echo on which the fluoroscopy can be superimposed as needed during the procedure. We prospectively collected data on 18 consecutive patients with severe aortic stenosis undergoing TAVR with a direct aortic approach. As a preoperative workup, all patients underwent an EKG-gated CT with 3D reconstruction, and we used the fusion imaging in the operating room with the heart and the Echo Navigator. As you can see here, the procedure is well planned in details. All the calcifications on the aortic valve and the ascending aorta are well identified. The optimal plane for the C-arm is also set. And we put a landmark on the ascending aorta about 6 centimeters or more from the annular plane in direct line with the aortic valve. Once the ascending aorta is exposed, we put a purse string in the previously identified soft spot in the ascending aorta, and we usually utilize a counter incision approximately 2 centimeters above the sternotomy in order to have a better and optimal angle for wires and sheath delivery, introduction and valve delivery. Mean age was 83 years old, and STS score was 7.4 with incrementals of 21.5. 5 patients had previous cardiac operations, and the aortic valve area was 0.59 centimeters square with a mean aortic gradient of 39 millimeters of mercury. The ascending aorta calcium score is as reported. Self-expandable valves were used in the vast majority of cases. We used a manubriotomy down to the second intercostal space in 72% of the patients. And in the 5 patients who did have cardiac surgeries in the past, we used a slightly larger incision down to the third intercostal space. Distance of entry point from annular plane was 7 centimeters on average, and the entry point away from atherosclerotic or calcified plaque was achieved in all patients, as well as the direct line with the aortic valve. Fluoroscopy time and total ventilation time are reported. We did have successful access and implantation in all patients. We didn't report any hospital mortality. None of our patients in this series had any transient or permanent neurologic compromise, and we didn't have any minor or major vascular complications, including aortic dissection. None of the patient was re-explored for bleeding. As a conclusion, direct aortic is an alternative approach for TAVR. The merger of live fluoroscopy with CTA and echo with the heart and echo navigators provides a safe and effective means to plan and guide direct aortic TAVRs. And the future will be to merge different modalities in only one screen image, in which the operators will be allowed to attenuate one of these modalities as needed in order to perform more complex hybrid procedures. And I want to thank the Society for giving me the opportunity to be here today. Thank you.
Thank you very much. Can we invite both speakers up to the stage? Any questions from the floor?
Lucian, So you have difficulty in looking at the subannular part of the 3D imaging. So most of you, the transcatheter mitral valve, depend on the subannular fixation because that's going to be the most crucial part for prevent migration. And although they're not perfect yet, but so how do you plan on accurately positioning your tabs or your four anchors into the mitral annulus subannulally? Fluoroscopy?
Well, a combination of the two, and probably fusion technology would. That's the way to go, and you've shown that very nicely in the previous talk. So actually, the tethering system with the Apex enables elimination and simplifies the procedure very much. And we're not sure whether you actually need the subannular fixation. However, we're experimenting with that. And that makes, we think, the valve we have, it has some advantages just because it's hard to reproducibly anchor anything under the annulus. They're just, we all know, it's a jungle in there.
So for Lugio, and I know we've been using these fusion images before I left Lenox Hill Hospital, retired from Lenox Hill Hospital. We're also doing the direct aortic just after that. Can you compare the before the fusion technology applications and the after the fusion technology applications? Any difference in the outcome and the procedural success? Because the cost of this is going to be very important.
Yes, we don't claim to have better results than other institutions. I think the procedure becomes more comfortable for the operators. There are more tools in the hands of surgeons and interventionalists to reduce complications, especially if there are calcifications on the aorta. And I think it's a good technology that is expanding and can really help in making these complex procedures more accurate.
Have you used this in MitraClip yet?
We do use fusion imaging on all our hybrid procedures. I showed today data on a direct aortic approach, but this is a multimodality support that we do use in all transcatheter interventions, yes.
I think it will be very good for the transcatheter mitral valve implant, especially the subannular plane. So.
Dr. Pirelli, can I ask you if you have information on the rate of renal impairment and rise in creatinine in your patients since you started using the multimodality approach?
Yes, one of the reasons why we are so into developing this multimodality imaging is also to reduce the amount of contrast that all these patients receive. As I showed, the baseline creatinine was 1.4, so basically almost all patients had some kind of renal impairment to start with. But we've been successful in using less and less contrast, and also the fluoroscopy time that is not related to the renal impairment, but also that time is slowly coming down and reducing postoperative dysfunction. None of the patients that we included in this series had permanent renal impairment, and some of them did have some transient increase in creatinine, but that resolved over the in-hospital course.
Fantastic. I also noticed that your main approach was an upper hemimanubriotomy. Given that you had such accurate assessments of the position of the aorta, did it ever make you change your approach to a thoracotomy, to a right thoracotomy? Did you find if the aorta was a little bit too much to the right side that you might consider a different approach to the one you normally use?
That can be considered. We do have experience on medium mini sternotomies, and that's also our preferred approach in surgical AVRs. I think with these modalities that we're using, an anterior right thoracotomy can be safe and can be done, but I don't have experience on this approach.
Thank you. Do you have any questions?
No.
Okay, well, thank you for two excellent presentations, and we'll move on to the next talk. Which one is that? Okay, thanks. The next talk is intraoperative detection of coronary